Yes, sir. It's visible.
Today we will discuss this topic in following order. As I said previously, that as prolapse has the occurrence of prolapse or incidence of prolapse has reduced in urban population, but it is still quite common in rural population, and sometimes it still can be seen in low socioeconomic class in even urban area. And management of prolapse is very important, especially the surgical management, which I am going to focus upon. I know the audience is mainly obstetric and gynec practitioners, so we will not go into details, too much details, although I am going to cover all these things. But still, the main thing I think is uterine support system, then the diagnosis and the management. So I think, and in the management, mostly surgical management, I will be discussing. So today we will be discussing first theoretically definition, types, terminology of regarding prolapse, then detailed description of uterine support system, what role does it play, what are the etiological factors, what are the aggravating factors which may be overlapping, then complications, diagnosis, investigations, and management. We will be taking questions after the presentation is finished. So the simple definition is descent of uterus into or out of vaginal canal and descent of vagina with or without uterus. So generally, clinically speaking, uterine prolapse is almost always associated with some degree of vaginal prolapse, either anterior vaginal or posterior. Hello. Hello.
Yes, sir. You are audible.
Okay. No, I had some noise in between. That's why I asked.
Yeah, yes. Sorry for that.
So the I was telling you, clinically speaking, descent of uterus most commonly associated, almost always associated with some sort of vaginal prolapse.
Sir, just a minute. Sir, just a second. Everyone in the NIMA-OBGY, I request you all to unmute yourself. Otherwise,
Mute yourself.
our technical team can remove you or keep in your mouth. So please, everyone, please unmute yourself. Please mute yourself. Don't unmute. Please mute.
The terminology of prolapse is like first degree of prolapse. Now some people, you can see here I have classified prolapse, means I have accepted the classification in of 3 degrees. But you will find later in the presentation that some figures are depicting degrees of prolapse. Clinically, for clinical management, the minute classification does not matter. What matters is how much is the descent, what is the uterine size, what is the vaginal size, and how much repair we need to do, and what kind of surgery we need to perform. So this classification shows first degree prolapse is normal position of cervix in the vaginal canal, anatomically placed is at the level of ischial spine, external os at the level of ischial spines. That is the normal anatomical position of the cervix in pelvis. So if the cervix starts coming down to that level, but it is still in vagina, okay, that is called as first degree prolapse. Second degree prolapse is cervix is coming out of the vaginal introitus, but the uterus is inside vaginal canal, or it may be in the at the upper level of pelvis also, if there is only cervical elongation. Third degree prolapse is also called as procedentia. Some people make the distinction of these two levels. Third degree prolapse, they call that whole uterus is out, but some part of vagina is still inside. And procedentia is uterus with cervix and whole vagina is out. That is called as procedentia. So this third degree may be divided into two types. Now, this was for uterocervical prolapse. Now, the terminology for vaginal prolapse is if anterior 1/3 or upper 1/3 of anterior wall is prolapsed, that is called as urethrocoel, because behind that wall, urethra is situated. Posterior 2/3 is bladder base, so that is called as cystocoel. Anterior 2/3 of posterior vaginal wall, the laxity or prolapse is called as rectocoel, and posterior 1/3 or upper 1/3 of posterior wall, if it is prolapsing or herniating, it is called as enterocoel, because there is pouch of Douglas in which intestines are there, and that's why it is called as enterocoel. After hysterectomy, if the dome of vagina comes out, it is termed as walled prolapse. As I told you, these are the 4 degrees of prolapse according to some classifications. This is the normal anatomical position. This is just starting first degree, just below the ischial spines. This is cervix at the introitus, but uterus is inside the vagina. This is cervix is outside vagina, but some part of the uterus is inside vagina. And in 4th degree, whole uterus and vagina is outside. So these are the degrees of prolapse pictorial presentation. Some more pictures. The side view, how the bladder wall, how the bladder base is pushing onto anterior vaginal wall and making it to herniate, causing cystocoel. The uterus is shown as somewhat at its anatomical position. This is the rectum and anal canal, which is pushing onto posterior vaginal wall, causing a rectocoel. Now, to understand prolapse and to devise a management for it, we need to understand the pathophysiology of prolapse. How does it occur? And to understand prolapse, we need to understand what keeps the uterus in its normal anatomical position. That is called as uterine support system. Now, there are 2 kinds of supports, anatomically speaking. One is false supports, which are the structures like broad ligament, loose pelvic connective tissue, fatty tissue, etc., which do not actually help the uterus in maintaining its anatomical position. Now, normal anatomical position of uterus is considered as anteverted, anteflexed. That is the angle of uterus to cervix and angle between cervix and vagina. Okay. So this position is maintained by the 2 supports. So anteversion of uterus is mainly maintained by round ligament. Round ligament starts at the uterine cornu anteriorly, anterolaterally, and it goes into internal inguinal ring, then travels through inguinal canal, comes out of the external inguinal ring and fuses with the upper part of labia majora. So this, whenever there is rise in intra-abdominal pressure, the anterior abdominal wall contracts, and due to that contracting action, the round ligaments are also stretched, and the uterus is pushed towards anterior abdominal wall, maintaining it in a normal anatomical position. So whenever there is rise in intra-abdominal pressure, if the round ligaments have their tone properly, the uterus will maintain its anteverted position so that it will not come down. When the uterine supports like round ligament becomes weak, then uterus becomes mid-posed or retroverted, coming into the direct line of vagina. The axis of uterus, cervix, and vagina become parallel. So instead of maintaining the angle, they become parallel. And when there is rise in the intra-abdominal pressure, this straightened out or retroverted uterus will be pushed directly into vagina, aggravating the prolapse process or making it faster. Now, this was about the anteversion and retroversion. Now, second but most important part is the lower part of uterine support. That is also called as uterine hammock. It is pubocervical ligament, cardinal ligament, and uterosacral ligament. These are 3 types of ligaments which support the uterus anteriorly, Anteriorly, uterus is supported by pubocervical ligaments. Laterally, it is supported by cardinal ligaments. And posteriorly, it is supported by uterosacral ligaments. Actually, these three ligaments are originate from the same pelvic fibrous connective tissue. It is the condensation. Okay. And then vagina. The vaginal anatomy is maintained by levator ani muscles, which encircles the vagina, urethra, and anus, maintaining their sphincter action as well as its supports. Also, vagina has a dense connective tissue layer, and then it is also supported in downwards part by perineal muscles. So, vagina maintains its angle of 45 degrees and its tone is also maintained. All these things maintain the uterus, cervix, and vagina in their normal anatomical position. And as I described previously, if the round ligament and uterine hammock become weak, then uterus will be pushed downwards into vagina and it will drag vagina along with it eventually. So this is the pictorial representation of the things which I described just now. So this is the lateral view, this is the sagittal view, okay, and this is a schematic representation. So here you can see the sacrum posteriorly, then pubic symphysis anteriorly. The pubocervical ligament, it goes around bladder neck, starts from the pubic bone, pubic rami, posterior aspect of pubic symphysis, goes to, means it circles around the bladder neck and goes to the anterior aspect of cervix. Then transverse cervical ligament, which is also called as cardinal ligament or also called as McIntosh ligament. It starts from the lateral pelvic wall and it is attached to the lateral wall of cervix on both sides. And this is the uterosacral ligament. These are two in number, which starts from the posterior aspect of cervix and they are attached to sacrum, sacral promontory. The position of uterine hammock is at the level of interloss. Hello? Did somebody ask something? Huh? And this is the round ligament which travels to the inguinal canal and goes out, which maintains the anterior anteverted position of the uterus. So you have to understand that these three supports at the level of internal os, that is the uterine hammock and round ligament, are the only things which are affected during the pathology of prolapse. Now, what are the causative factors? The causative factors are listed as any factor causing the uterine support system to become weak. For example, congenital weakness. There are some patients, some young females who have some degree of descent, which might be realized when they start having some symptoms, or sometimes when they have some pregnancy complications like misabortion, or means what happens during pregnancy, there is increased blood supply to the pelvic organs and they become slightly pliable and softer due to relaxin hormones. So at that time, the prolapse, which was not previously present, might get aggravated, or it might start at that time. So pregnancy during young age or during reproductive age may enhance prolapse who have congenital weakness of their support system. Multiple vaginal deliveries, multiparity, causes prolapse. It is a known factor because human vaginal birth is one of the most difficult labors or deliveries among the animal kingdom, because we are blessed with a large brain. It causes the cranium to become large. So vaginal delivery in humans is quite difficult if compared to other animals. No other animal has globular head, and that globular head causes quite a lot of, it makes the pelvis to make adjustment, a lot of adjustment with the head size. Head also makes adjustment like molding and all. And then it comes out after a lot of struggle. And this struggle, if it's complicated by like CPD, means the head is large as compared to pelvis, or vice versa. Pelvis is small as compared to, or in general contracted pelvis, or there is some problem, or the baby is too large, or the contractions are not proper, so the labor gets prolonged, or the patient starts bearing prematurely, or the episiotomy is not performed on the time, then these things will stretch and tear the uterine support system as well as pelvic muscles, pelvic floor, etc., which will cause weakening in those support systems, leading to prolapse later in even during reproductive life or after menopause. If the first delivery happens at older age, like elderly primipara, like at the age of 32 or 35, if first vaginal delivery happens at a later age, then it can aggravate prolapse because of the age-related changes. Difficult labor or delivery, as I told you earlier, that prolonged labor, premature bearing down, improper management of second or third stage, and trauma during childbirth. Now, trauma may be because of a large baby or because of hasty delivery or some complications like precipitate labor, cervical tear, vaginal tear, especially in the upper part of vagina, or perineal tears, like second or third degree perineal tears, which may cause weakening and devitalization of the tissue. This is the main thing which enhances the chances of prolapse. Devitalization of tissue, trauma, irregular tears, and infection in those tears will eventually may lead to weakening of the tissue and prolapse. Delivery of a large baby, as we have discussed, being overweight sometimes is said to have some effect on causing prolapse. These are aggravating factors like prior pelvic surgery. Suppose the patient had like some perineal tear or vaginal trauma and it was repaired, and or it was not repaired properly, or it got infected, then it might enhance the chances of prolapse. Family history of weak connective tissue, this factor I already discussed, like it is a congenital factor, genetic factor. Home delivery. If this practice is common in rural areas where the deliveries are obviously conducted under septic conditions, or you can say without any aseptic precautions, or the patient may not get into hospital at proper time. She may get delivered during the journey without any episiotomy, without any support like oxytocin or hydration. She might be anemic, she might be hypoproteinemic, which are nutritional factors. All these things can lead to prolapse. Low estrogen level after menopause. In many patients who don't have any symptoms of, or signs of prolapse may suddenly start after menopause, because when the uterus, cervix, and vagina lose their estrogen support, their thickness, their strength obviously reduces, and they start becoming lax and start coming down. Chronic constipation or straining with bowel movements. So this is one of the major factors which can cause prolapse and which can go undiagnosed sometimes, because patient, if we don't ask, patient may not tell. Chronic cough or bronchitis obviously will raise the intra-abdominal pressure, and which can increase the chances of prolapse, especially after menopause. Chronic cough, for example, suppose the patient has history of TB. If pulmonary tuberculosis, then obviously she will get after effects of tubercular infection. She will lose weight, she will become malnutrited, she will lose her muscle vitality and tone, and that may also add to the pathophysiology of prolapse. Repeated heavy lifting, which is quite common in people or females who are working in farms or in the rural areas, who have to lift quite a lot of weight, or lift buckets, or lift water from wells, or carry carry loads for a long distance. In such cases, or not getting enough rest after delivery. Many people who are manual laborers or construction workers, you may have seen such people carrying their early newborns in their laps or along with them and working. So this is quite a difficult situation for such people. So they start lifting weights, or they start training their tissue even before it heals properly. And as well as malnutrition and anemia will also contribute. What are the symptoms of prolapse? Okay. The patient feels some dragging sensation. Mostly the patient will tell you that something is coming out of her vagina, or she feels some swelling there. Okay. And rarely some patients will tell you about dyspareunia, some patients will tell you about some urinary symptoms like retention of urine, or difficulty in passing urine. Some patients may develop bladder stone due to long-standing residual urine, repeated urinary infections, incontinence, especially stress urinary incontinence. Okay. These are the symptoms of anterior vaginal wall or cystocele or uropocele. And rectocele is something bulging at the time of defecation, or not able to pass stool effectively. Okay. So these are the most common symptoms of prolapse. Sometimes chronic pelvic pain or dragging sensation in the lower abdomen may also be seen in some patients. What are the signs? When we examine the patient, we will see normally the labia minora are opposed to each other, or they may be slightly parted, but otherwise there is nothing coming out of vagina in normal situations. So obviously when the patient has marked prolapse, then she will have some swelling in the vulval region. Okay, and then you will observe. Sometimes the swelling is confusing also. So this is very important to differentiate where the swelling is originating, whether it is anterior vaginal wall, whether it is cervix, or whether it is posterior vaginal wall. One thing to be mentioned, which is important here, is sometimes, very rarely, actually we don't observe such cases now, but sometimes you may come across such patients, like something is coming out, but it might be a cervical polyp, it might be a vaginal polyp, it might be a fibroid polyp, which is arising from the uterus, but coming out of cervix and out of vagina. It is a sessile polyp, fibroid polyp, which may look like prolapse, especially after it gets infected and starts growing in size. Then the patient gets confused, and sometimes new doctors may also get confused. So it is necessary to do a per speculum examination properly with sim speculum and visualize the organs properly. Sometimes, very rarely, the books have described this condition that chronic inversion of the uterus may be confused with prolapse. Rarely. Nowadays, we don't observe such cases much, but fibroid polyp we have observed that it comes out of vagina, and we feel initially that it might be a prolapse, or it might be a cervix which has infected decubitus ulcer. But after examining properly, you may be able to rule out. So this is important for differential diagnosis while examining the patient of prolapse. So any swelling in vaginal region should be examined properly. Then you will, if it is a prolapse, then you will have to decide the degrees of prolapse, whether it is first degree prolapse, second degree, third degree, or fourth degree, or first and second, third degree. If the prolapse is chronic, especially in aged patients or patients of rural area, or even some cases of urban area also, we have observed over the years that the patients are shy or they are embarrassed to share such things with their family members, even husband or their daughters or their daughter-in-laws. Sometimes they are also shy of their doctors also. So such patients develop decubitus ulcer due to long-standing exposure and friction. Now, some books have described decubitus ulcer as the effect of friction with and drying due to exposure to air. But actually, it is a symptom because of the sloughing of vaginal mucosa due to avascular necrosis. Because the dependent part starts becoming edematous, and slowly the blood supply gets cut off, and that forms this necrotic ulcers called as decubitus ulcers. Very rarely, if there is incarcerated prolapse and long-standing decubitus ulcers, they may get into squamous cell carcinoma, but it is very rare. The books have described that. I have not seen such patient in my practice yet. Cervical erosion. Obviously, the patients are multiparous, already there is erosion, but because of prolapse, the pelvic congestion increases, and that might increase the cervical erosion. Stress urinary incontinence. This is an important symptom. The patient tells that whenever she lifts any weight or whenever she squats and tries to pass urine, whenever there is any rise in intra-abdominal pressure, there is involuntary passage of some amount of urine. Okay? And then some people just feel laxity. And few people will complain of constipation, chronic constipation, especially if the rectocele is huge. These are some pictorial representations. This is the laxity or prolapse of anterior vaginal wall. These are the labia minora. This is urethral meatus. This is the posterior 2/3 of the anterior vaginal wall, and this is the urethra. Okay, so if this bulge is called as cystocele, and in lateral aspect it will look like this. The normal anatomical position is like this, but this much part has herniated. Okay. Now you can see the difference between these two figures. Here the bladder bulge is more, but urethra is normal. You can clearly visualize the bladder neck, the angle. But here the angle is slightly obliterated, and urethra has become straighter. Normally there is an angle between bladder neck, means the bladder base, and urethra. So it acts as an internal valve, and the urine does not come out whenever there is a rise in intra-abdominal pressure. But because if the urethra is also prolapsing, this angle gets obliterated, it becomes straight. And so the urine starts coming out involuntarily, especially when the patient lifts any weight or there is any rise in intra-abdominal pressure. So this bulge is called as urethrocele. You can see the urethra has become wide and straightened. It is not narrow like this. It has become wide and straighter. The angle is lost. And similarly, the rectum is also bulging. This is the peritoneal body. This part, it starts bulging out. Eventually, it will cause this part's laxity too. Okay, and this part, vaginal wart, the posterior, the POD, if it starts bulging inside, that is called as the enterocele. Means this stone will get lost. This POD will come down with intestine in it. That's why it is called as enterocele. Okay, so this is the rectocele which I was describing, which is pushing the posterior wall out, posterior vaginal wall out, and causing a huge bulge there. And obviously, the stool will get retained in this part, and it will cause constipation because the sigmoid and rectum will lose their natural position. These are some figures. Now, this is a huge cystocele. Urethra is still in normal position, and this is external os and cervix. Okay. So this you can call it as a third-degree prolapse. Now here you can see that only the cervix is out. It has brought some anterovaginal wall with it, but you can see that there is no bulge here like this. This is cervical elongation. You can call this only uterine prolapse, and you can call this utero-vaginal prolapse. Here the anterovaginal wall is still inside the vagina, some part of it at least, and there is no bulge at the site of bladder. So this will be termed as uterine prolapse with cervical elongation, and this will be termed as utero-vaginal prolapse with huge cystocele. These red markings are developing decubitus ulcer, which may develop later. Now, what are the complications of prolapse? The patient has some patients develop continuous pelvic pain because of pelvic congestion, because all the pelvic organs are, especially reproductive organs, are getting dragged down. So the venous return will reduce and there will be venous congestion in the pelvic organs, leading to chronic pelvic pain. Stress urinary incontinence, as I have described, that when there is loss of angle between urethra and bladder, the urine starts voluntarily coming out and causing stress urinary incontinence. Repeated or chronic UTI because of residual urine. Residual urine is whenever the female passes urine, there should be no or very minimal amount of urine left in the bladder. Okay. So generally, to rule the residual urine out, we have to see how much urine is left after the patient passes urine. So sonologists or radiologists do two kinds of sonographies. One is pre-void volume, means they do ultrasound and measure the volume of urine which is in the bladder, and they ask the patient to pass urine and then do sonography again to see how much urine is left in the bladder. Okay. If this volume of urine is above 50, 60, or according to some books about 75 cc, then it is considered as significant. Less than that, it is not significant. If it is above significant volume, then it is termed as residual urine. That much urine will always be there in the bladder, even after passing. And the patient may feel repeated urge to pass urine. But most importantly, this passage of urine. मी लेक्चर घेतोय, झूम वर लेक्चर चालू आहे माझं ना, मला नका सांगू दे. Sorry to miss. So the patient may suffer from repeated or chronic UTI due to these anatomical changes and residual urine. Dysuria, obviously, she will. Hello. Can I continue?
Yes, sir, please.
So this dysuria, means difficulty in passing urine, is because of the changed anatomy. Dyspareunia, change anatomy and infection also. Dyspareunia is obviously because of vaginal laxity, or if the uterus is out of vagina or in the vagina, like first or second degree, then it will obviously cause difficulty in copulation. Prolonged labor, it can happen if the patient is having young age prolapse or prolapse during pregnancy. I had a very peculiar case, if I may digress somewhat. I had a patient of 28 years old. When she was priming, she came with 12 weeks pregnancy with central placenta previa, with her cervix totally outside the vagina. So this was a very curious case which we managed by conservative management, but I will discuss the case later in detail. So as the cervix is already outside, the anatomy has changed, and most importantly, the support system has weakened. The pelvic floor tissue, then the supports of uterus. Obviously, if they become lax, they will not be able to push the baby out properly, and the angle or the angle of birth canal will also change considerably. So prolonged labor is a common complication of a prolapsed uterus. Chronic constipation, we have already discussed it. Decubitus ulcers, we have discussed. Incarceration of prolapsed uterus and vagina. If the uterus and vagina are outside, outside for long period of time, because of venous congestion, edema, ulcer, and infection, they may become stuck and become irreducible. Like an irreducible hernia, it becomes stuck and cannot be reduced, and the patient is in tremendous pain. Again, it's a rare complication. Now, how to diagnose? Now, diagnosis is comparatively easy, as you can see what is there with your naked eye. There is no need to do internal examination. Even external examination will reveal many things. But still, history is important. Means, what are the causative factors? This history is important in formulating the plan. If the patient gives history of TB, patient gives history of chronic cough, the patient gives history of chronic constipation, then obviously you will have to work on those factors in order to prevent further complications after surgery. Otherwise, the patient, you will remove the uterus, you will repair, but if the factor remains there, then the patient will suffer from word prolapse like complications or other complications. Then local examination should be done very carefully, especially when you are inexperienced. So I know the seniors also know that seniors already know this, but I will discuss this briefly for benefit of the junior surgeons. Local examination as a clinician, generally, whenever we do a PV examination in a gynec patient, or even during obstetric patient in labor, we do it with empty bladder, because we want bimanual palpation in first trimester or gynec uterus, and to judge the degree of descent in full-term patients. But in case of prolapse, to rule out incontinence, stress incontinence, we need bladder full, because the uterus is mostly outside, or some part of the uterus is outside. So most of the time there is no need of performing or bimanual examination, or you need to do bimanual examination, because sometimes prolapse uterus is associated with space occupying lesions like ovarian cyst, or fibroid uterus, or a fundal fibroid, or a posterior wall fibroid. In such cases, the management, you have to plan it very differently. So associated things like that can be observed. But initial exam, starting of the exam should be done with full bladder. Then you can ask the patient to cough while separating her vulva, so that because of raised intra-abdominal pressure, urine will come out if the patient has stress incontinence. It will not come out if there is no stress incontinence, or it will not come out if the bladder is empty. So it is preferable, or it is good practice, to perform local examination with full bladder, at least at the start. Then if you want to rule out some other lesion, or want to do bimanual palpation, then you can ask the patient to pass urine and come back and do her bimanual PV examination again. Okay. Then use sim speculum properly, preferably 2 sim speculi. If the vagina is quite wide, in postmenopausal patient, you can use 2 sims, but of smaller size. So use sims properly, visualize the cervix properly, because many times, as you saw in the previous figure, the cervix is not quite visualizable properly. When the cystocele is too large or rectocele is too large, then you get confused. So first, always find out the external os, grasp it as gently as possible, and try to pull it. Many patients may have some drag on their ovaries and round ligaments, so they will feel tremendous amount of pain. So you have to be careful while performing this stretching or pulling down. But this pulling down will give you an idea how much uterus or cervix is coming out, how much bladder and rectum is herniating, how much guts are herniating, that is enterocele. Sometimes what happens, or in most cases, when you are examining the patient without anesthesia, the degree of prolapse which you will diagnose will be lesser. But when patient is under anesthesia, then the degree of prolapse will be higher. Because of anesthesia, there is no pain as well as there is relaxation of muscles and pelvic tissue. So the uterus will come out more than when the patient is conscious. So you have to keep this thing in mind. So always do another examination before surgery, means after administering the anesthesia. So after ascertaining the degree of prolapse and after ascertaining the degree of cystocele, rectocele, urethrocoele, enterocele, etc., then you can formulate the plan. Or if local examination reveals that there are decubitus ulcers, then you may have to postpone the surgery. If the patient is too old, then you may have to postpone the surgery, or you may have to devise totally some other management like conservative management, like ring pessary or Leafort's surgery, which will, because some old age patients may not be fit for surgery due to anesthesia risks or general factors. I have come across some patients with chronic illness like pulmonary tuberculosis, in which you may have to postpone the surgery for few months till the patient gets cured. It is beneficial, as well as patient will not be fit if her lungs are affected with tuberculosis, and you may not be able to operate her properly, or her malnutrition status or her other complications may cause other complications during your surgery or in post-operative period, and it is not beneficial for your patient. So it is better to perform local examination very carefully so that you will rule out these things, the degree of prolapse, any other complicating signs, and then plan the treatment accordingly. Systemic examination to rule out aggravating factors like chronic cough or constipation, etc., which we have already discussed. Investigations to be done, a short list: routine blood investigation in which we do hemograms, then blood group, blood sugar, HbA1c, thyroid function test, then the serology, HIV, HBsAg, VDRL, etc. And other blood investigations if the patient is aged or having some medical complications like hypertension, diabetes, or both, or some heart condition, then LFT, RFT, lipid profile, all these tests will have to be done depending on the physician's reference. Radiological examinations, most common examination which is done is investigation is USG abdomen pelvis, which will give you idea about pelvic organs. Some radiologists also mention that the uterus is placed downwards in the vagina or some part of it is coming out to rule out prolapse, etc. They will mention that, but even if they don't mention, we know that from clinical examination. But sonography will reveal if there is any other complicating factors, as I previously mentioned, like ovarian cyst or pelvic mass or pelvic, uterine fibroid, etc. So that you will be clear in your mind while formulating the plan for surgery. And if there is some SOL or if there is some upper abdominal lesion, then you can do MRI or CT to rule that out, and then your management will change. Chest X-ray is routine. 2D echo for aged. Most of these patients are aged, so we have to do chest X-ray and 2D echo. And nowadays, especially in urban areas, the physicians always want chest X-ray and 2D echo, ECG, etc. examination, even in younger patients. So it's better to do them. Medico-legally also it is very important. Physicians and anesthetist reference for surgical fitness. Physician gives you fitness when the patient is resting on his table, but anesthetist sometimes is a better judge because they know how the patients may behave under anesthesia. So it's better to take both of their opinions. Now management. Now prevention. In some cases, we can prevent prolapse, or we can anticipate those factors which can cause aggravation, as we have previously discussed, and then we can formulate the plan accordingly. for prevention, or you have to keep this thing in mind while conducting delivery or during examination of any ANC patient or during examination of any gynec patient also. What is her history? So these things, as a gynecologist, as a clinician, you have to keep this in mind to formulate management plan. So treat chronic constipation or chronic cough. These are the most common aggravating factors for prolapse, especially in old age. You have to treat them properly, finding out the cause, treating the diagnosis. Then this is very important, intranatal precautionary measures. We were always taught, nowadays it is, I have heard or I have seen some practices, new practices in obstetrics, like delivering a patient without episiotomy. It has become common in some Western countries, or it is also common in some urban areas in India also. But we were always taught, we know the benefits of that teaching. We were always taught, even the patient is 10th para, always take an episiotomy. This may sound an overstatement or overdoing things, but we were taught, and books also tell, that whenever you take an episiotomy or you cut the perineum properly in surgical incision, then when it is sutured and heals, it will create fibrosis, and fibrosis will offer support to the vagina and perineum, thereby reducing the rate of progression of prolapse, or it may altogether prevent the prolapse sometimes. So if you are practicing episiotomy, then the proper timing of episiotomy should be followed. Then patient has to be told to avoid premature bearing down. The patients who have posterior position, POP, or long rotation in first stage, they may start bearing down prematurely because of because of acute backache. So you have to avoid that. So you have to consider epidural anesthesia, or nowadays it is becoming a common practice in urban area also to give epidural during delivery, so that these things can be avoided. So timely episiotomy. Timely episiotomy means when? Many books have mentioned that episiotomy should be taken after crowning. Means when the head is at the introitus and it is not receding back even between contractions. That is called as crowning, which means the head is now fully in vagina and it is stretching the vagina fully. At that time, you should take episiotomy so that it will bleed less and the head will come out immediately. Now, I have some slightly different opinion about this, and I have read it in some books also. If we allow the vagina to get it stretched fully, then what is the rationale in taking episiotomy? Then you might as well continue the labor and perform the delivery without taking episiotomy by stretching the vagina manually, or by taking whatever precautions they tell you in episiotomy-less delivery. So my personal opinion, and some books have also mentioned that episiotomy should be taken just before crowning, because crowning will completely extend or expand the vagina or stretch the vagina, and then your purpose is failed. Because if it is stretched to its limit, obviously it will become lax later. So to avoid this laxity, you have to maintain some tone of vagina, and to maintain that, you have to perform the episiotomy slightly before crowning happens. And when crowning happens, there is no point. So before crowning, take episiotomy. Try to deliver the baby as fast as possible. So you can cut short the second stage by judicious use of vacuum or forceps in selected cases. But usually, if the patient is bearing down properly and contractions are good, the power factor is good, the baby will come out immediately. Okay. So according to my opinion, episiotomy should be performed just prior to crowning. I have seen that. It helps. Proper asepsis. Many obstetricians, I'm not accusing anybody, but please bear with me for some time. They are very casual about asepsis during normal delivery. I have seen many senior obstetricians performing episiotomy without a drop of betadine being applied, which is very wrong. Actually, Perineum is quite soiled during delivery. We all know that the patient passes stool, the patient passes urine. So it is always good. It is always good to follow the books here. Whatever aseptic precautions you can take, you should take. Because even though perineum is quite vascular, the episiotomy heals, but we should not take it for granted. 98 patients will go without any complication, but 2 patients will suffer because of our negligence. So that is very important to follow proper asepsis, to follow proper conduction of delivery, labor protocol, and repair of episiotomy with proper suture material, and avoiding leaving any gaps or hematoma or blood inside the episiotomy wound. So we should not be casual, even though we are delivering 8 or 10 patients daily. This happens, especially when you are learning, when you are working in a large institute where there are 10, 15 deliveries every day, so we become casual about it. But it is not. It is not our. It is not proper on our part to become casual for, because every patient and every life matters to us. So this is our basic motto: do no harm at least. This is the doctor's first principle in medicine. If you cannot cure a patient, at least do no harm. So repair of episiotomy, proper antibiotic coverage. The technique by which you repair means filling all the blank spaces, like leave no space between muscles or between muscle and mucosa, or between muscle and skin. Okay. And if unfortunately there are perineal tears, their repair should be meticulously done. Pelvic exercises postnatal, but this is the most ignored part. Nobody takes this seriously, not patients and not even gynecologists. But I think Western countries are can advocate things like episiotomyless delivery, because they have the patients and they have the protocol to follow after delivery, like strengthening of pelvic floor muscles. The pelvic exercises in postnatal period, especially 4 to 6 weeks after normal delivery or 8 to 12 weeks after cesarean section, have to be done. Generally, after cesarean section, you may not need such exercises, but in some patients where we have to perform cesarean section very late, after the patient has become fully dilated or the head is partially in the vagina, so already there stretching and tearing of muscles and tissue has happened. So it is important to advise in such patients the postnatal pelvic exercises. We have devised a postnatal plan in our hospital, and we advise those pelvic floor strengthening muscles, bladder, neck strengthening exercises for these patients. Avoid heavy lifting, especially in immediate postpartum period or after menopause, or if you already have some kind of prolapse and if the doctor has advised you, then avoid heavy lifting. Nutrition and balanced diet during especially postnatal and perimenopausal period. Postnatal period is because the patient is already, the tissues are devitalized. As we say in Ayurveda, Sutika is Vrani and Kshati. Okay. And in perimenopausal period, where the tissues lose their estrogen support, they become weak. So here the nutrition matters. Nutrition, exercise, the lifestyle matters. So even if you compare two patients, one who is not following these things and one who follows these things religiously, obviously the second patient will benefit. Then there is some conservative management, which I have already touched upon. Pelvic exercises for perineal laxity or minor degree of prolapse, especially first degree of prolapse, mild cystocele, rectocele, or there is just in general laxity, especially when the patient complains or the truly speaking, sometimes the husband complains that her place has become too loose. This happens. The patient comes with such complaints. Nowadays, we do pelvic cosmetic surgery for such patients to tighten the perineum. You can do that also if the patient or the couple desires, or there are actually medical tourism for this from some Arabic countries. So we do those surgeries for such patients. But lesser degree of prolapse or minor laxity of vagina can be managed for a long time, although not completely, but for a long time with pelvic exercises and proper diet and lifestyle. Ring pessary. Ring pessary is a conservative management to postpone the surgery, especially, or to manage the prolapse or avoid complications of prolapse during pregnancy. That patient which I had, which I described before, which she came at 12 weeks with central placenta previa and total cervix out of the vagina. I had no option but to insert a ring pessary, and we used to clean that pessary repeatedly after every week and again fit into that. After 20 weeks, not after 20, but 24 weeks, the uterus, when it sat up on the pelvic brim, then the cervix went inside. So up to 24 weeks, she had to be fitted with a ring pessary. Then, but we couldn't, means her placenta didn't migrate, so we had to do her cesarean section. Curiously, the thing was she had similar conditions like prolapse, then central placenta previa, and cesarean section in second pregnancy also. And most importantly, she did not have any prolapse between pregnancies. She still doesn't have prolapse. She's now 38 years old. So there is a curious thing that her ligaments were selective only during pregnancy. Then I had another patient who was 70 years old with history of pulmonary development, not active, but she was not deemed to be not fit for surgery by the physician and the anesthetist. So we withheld her surgery for 6 months, but she had developed decubitus ulcers and she was suffering quite a lot and she was having tremendous pain. So we inserted a ring pessary for 6 months. We changed, which we change intermittently every 1 or 2 weeks. And then we had decided that if she doesn't become fit, then we will perform a Leapfrog operation. But fortunately, she became fit for surgery, and then we did a total Mayo operation for her. Now comes the main part, the surgical management of prolapse. Now there are two kinds of surgeries. First is conservative surgery like uterus preserving surgeries in which the patient is in premenopausal or reproductive age or very young, and she is between pregnancies and she wants another issue, or she doesn't want to lose her uterus. Then these surgeries are performed. Now vaginally, there are some operations like Fothergill's operations, or it is also called as Manchester operation, in which the elongated cervix is cut at the level of ischial spines. We first measure the cervical length using a sound or using a long dilator, and then we cut the cervix accordingly. Then the vaginal vault or the vaginal cuff is sutured on the cervix, again restoring the anatomy. Okay, that is the one step. But after dissecting bladder anteriorly, slightly, laterally cardinal ligaments are exposed and a slight posterior dissection is done. Here the most important step is shortening of the cardinal ligaments or McEnroe ligaments or lateral cervical ligaments. All these are same. So here we do shortening by, now they are normally attached on the lateral wall of cervix. So we put a clamp there, we cut them, taking proper precautions, means proper clamping and transfixing, and then we transfix those both McEnroe ligament on anterior wall of the cervix centrally, so that they will be pulled 1 or 2 inches medially, and there will be relative shortening. In 2 lax patients, you cannot cut also then, but it is very difficult because you have to do lateral dissection. But otherwise, this much shortening is quite effective, especially in young age. And then we cut the cervix and we suture the vaginal wall or vaginal cuff over the exposed part of cervix and recreate the external os and recreate the portio vaginalis of the cervix. Here, you need to take extra precaution if you are cutting the cervix to dilate the cervix at least to number 8, so that when the wound heals, it will not get occluded. Otherwise, the os gets occluded and the patient may develop cervical stenosis. So that is Fothergill's operation. anterior colporrhaphy and posterior colpoperineopathy. Okay. In some patients, the patient may not have much uterine prolapse, but only vaginal prolapse. In such cases, you can only perform those repairs. We are going to discuss these repairs later. Colporrhaphy means repair of vagina. Colpos means vagina, raphy means repair. So repair of anterior vaginal wall is called as anterior colporrhaphy. And posteriorly, we do perineal repair plus vaginal repair. That's why it is called as colpoperineopathy. Abdominal route, you can do posterior bilateral sling or unilateral sling. Here a marceline tape is threaded, is anchored to the anterior aspect of sacral promontory beneath the retroperitoneum, and then the sling or the marceline tape is woven through the retroperitoneum, medial, just medial to the iliac vessels and ureter, and it is anchored on the insertion of uterocervical ligament, posterior aspect of the cervix, and then it is pulled till the prolapse is corrected, and then the retroperitoneum sutured, and the sling is also fixed and shortened. This is on right side. On left side, there is sigmoid colon which we have to bypass. So we create a loop in the iliopsoas muscle, and then we weave the sling through it, and then we fix it on the left side uterosacral side, on the posterior aspect of cervix. So this is unilateral or bilateral sling. Here the precautions to take are: select the patient carefully, because many times this operation fails. So either you have to be very clear about your anatomy, your measurements, how much to pull the uterus upward should be correct, and there is always a chance of rejection of this material. If the patient's body rejects the foreign body, then you may have to remove that sling by opening or by vaginal route, which is quite a cumbersome task, and the patient is quite unsatisfied with us. So, and while weaving the marceline tape through retroperitoneum, we have to be careful about not injuring the ureter or the large pelvic vessels, iliac vessels, or sigmoid colon on left side. That is a very delicate and skillful surgery. And you have to cover the retroperitoneum properly so as not to enhance the chances of rejection of the sling. Pectineal sling is done in the region of pectineal ligaments on anterior side, which is many times is done for young age prolapse or involved prolapse also. So these are the uterus preserving surgeries. Now radical means not radical as such, but vaginal hysterectomy, in which you will be removing the uterus, especially when there is second or third degree uterine prolapse and the patient is in perimenopausal or menopausal age. Then you have to perform vaginal hysterectomy. Now the case which we saw, in which there was only uterine prolapse and cervical elongation, in such cases you can do only vaginal hysterectomy without any vaginal repair. There are such cases. Or currently it is a trend that if the patient has a normal vaginal deliveries and if there is slight laxity, but you are doing hysterectomy for some other indications like fibroids or adenomyosis or DUB, then in such cases you may do NDVH, that is non-descent vaginal hysterectomy. So here, if the uterus is normal size or slightly bulky, it can come easily. But if the uterus is large, more than 12-week size or 14-week size, some people are doing up to 18 to 20-week size uterus also. But here you may have to dissect or bisect the uterus in order to get access to the lateral part of the uterus for placing the clamps. Otherwise, you will not get the place to place the clamps. And here, most of the times, the surgeons use biclamps instead of suturing, because you sometimes may not be able to see the needle through so much large mass sitting in the vagina. So biclamp is a better instrument in such cases. So bisection of uterus, pushing one part upwards so that you can get some space to place the clamp, and placing the clamp using biclamp. It is a bipolar instrument which you apply and press the foot pad. It will cauterize the tissue, seal the vessels, and you can cut using snips of your scissors. Only side effect of this instrument is it can cause vaginal burns. And if you go too deep into the abdomen, it can cause intestinal burns also. So you will have to be very careful. Mayo-Wart's operation. This is the most commonly observed and seen operation and done operation in vaginal uterovaginal prolapse. Here, if the patient is having second or more degree uterine prolapse and cystocele reproduction, that is anterior and posterior vaginal wall prolapse. So here we do 3 operations together. That is called as Mayo-Wart operation together. One is vaginal hysterectomy, means first we remove the uterus vaginally and then we repair both the walls, that is anterior colporrhaphy and posterior colpoperineal. If the patient is having urinary stress incontinence, then vaginally you can put Kelly stitch. Kelly stitch is like when you are doing cystocele repair, you dissect the bladder or you push the bladder upwards till the pubic rami are reached. That is a normal anatomical position of bladder base. And there, using Mersilk or non-absorbable thread, you anchor the thread to the periosteum of inferior aspect of the pubic rami, and you anchor that thread to the bladder neck. After placing the catheter in, if you place it before catheter is in, it might kink the urethra, or the stitch might go through urethra. So first, always put a catheter after dissecting the bladder, and then only take Kelly stitch. Okay. Birch repair is done extraperitoneally, but by abdominal route. Here, we dissect the bladder just before, means we open the abdomen up to peritoneum, but we don't open the abdomen. Beneath the rectus and pyramidalis muscles, we go up to pubic symphysis and bladder neck. We already place a Foley's in bladder so that we can know where the bladder neck is. And then similar kind of stitch, like Kelly stitch through the periosteum of the pubis or the pubic bone, and it is anchored to the bladder neck, so that you can restore the anatomy of the bladder neck and stress urinary incontinence either gets cured or it is reduced. But these surgeries need experience and skill. Conservative surgeries like Leaphort's operation. Here, the patient is not fit for surgery and you cannot remove her uterus or you cannot give her anesthesia for a long time. Then you remove the strip of anterior and posterior vaginal wall and suture them together. So the uterus will remain upward to the suture line and vagina will get fibrosed. But at the same time, whatever discharge is coming from the uterus and cervix or vagina will come out from the 2 lateral channels. The vagina is closed centrally and laterally there are 2 channels which are open for discharge to come out. Okay. So in such patients, you can do conservative surgery. So these are some. Now, there was one trend which urosurgeons used to do. Means they used to perform a sling like operation for cystocele or urethrocoele or stress urinary incontinence. Means they used to anchor one proline mesh like strip to the pubic symphysis or pubic rami, and it was used to cause fibrosis and ultimately repair the symptoms. But over the long period of time, the meta-analysis of many studies have shown that our conventional cystocele repair and Birch or Kelly stitch repair gives similar results. Sometimes the sling itself, so the mesh itself causes some complications like foreign body reaction or infection or discharge or bleeding, etc. So it's nowadays most of the gynecologists do not use these things. One thing I forgot to mention is uterine preserving surgeries or wall prolapse surgeries nowadays, especially the abdominal surgeries like posterior sling or pectineal sling, can be done laparoscopically also. And the patient does not need a big incision, and with skilled hands or under skilled surgeons' hands, these surgeries can be quite successful. But still there is some reservation about how much successful laparoscopic prolapse surgeries are. I have personally seen mixed results. So I am either or, both open or laparoscopic sling surgeries. Now, important tips during surgeries for junior surgeons. While doing vaginal surgery, what I have written is my experience. I'm not saying this is the last word. Okay, everybody has to develop their own technique. Everybody does according to their convenience. So I avoid too much fluid for hydrodissection, especially in posterior wall, because I have experienced sometimes that the plane gets lost and you may not find the pouch of Douglas properly if there is too much fluid between posterior uterine wall and vaginal wall. So I personally do not inject much of fluid posteriorly, but I inject adequate normal saline anteriorly and laterally. Okay. Always open posterior pouch first. This the books also advocate, because sometimes it happens when you are dissecting the bladder anteriorly and the vessels over cardinal ligaments or due to chronic cystocele, the bladder is very vascular or the vagina is also vascular. So the bleeding starts pouring in and you may not be able to find the posterior pouch, especially if you are a junior surgeon. It doesn't matter when you become experienced. But if you are a junior surgeon just starting to do vaginal hysterectomies, then it is always better to go by book. Always open the posterior pouch first. It is important because you can ascertain the extent of uterine fundus, important thing, and you are certain that you have at least access to one pouch. Sometimes it happens if the uterus has some anterior wall fibroid, or if there is previous section, there is previous surgery on the uterus, sometimes the anterior peritoneum gets stuck or fibrosed. In such situations, placing your fingers in the POD and bringing them anteriorly by crossing the broad ligament laterally or uterine fundus if the uterus is small helps in bladder dissection, and you can avoid bladder injury if the anterior pouch opening is difficult. That's why always open the posterior pouch first. This important tip I have learned: tie every clamp doubly. If you are using thread, if you are not using biclamp, if you are using thread, use always vicryl, number one, and always tie double. Means take two sutures separately. Okay, one suture. After that, place another suture lateral to it. Okay, so while transfix both the clamps and tie it doubly, because I have seen one patient develop slippage of ligature and she started bleeding from the ovarian clamp, and we had to open her abdomen, and then it was a mess. So it is not a good thing to become casual here. Always tie every clamp doubly. If you are using biclamp, then make sure the hemostasis is correct, the patient's BP is good. Okay, and always better to do proper hemostasis, 5-6 mm area at least, so that the vessel occlusion will be proper. Anterior, while doing anterior colporrhaphy, you have to know your landmarks. Make sure the bladder is pushed up to the level of pubic rami. That is the normal anatomical position of bladder base. While generally when we take vertical incision on anterior vaginal wall to start dissecting the bladder, we grasp the vaginal edges with Ellis, and we do some amount of sharp dissection to start the bladder dissection. At that time, take as much vaginal tissue as possible so as it supports the bladder, because anteriorly there is no muscle between anterior vaginal wall and bladder. So always use as much vaginal tissue as possible, because it is generally edematous and thick, especially if the patient is in reproductive age or just around menopause. If it is postmenopausal, it doesn't matter. But if the vagina is thick because of chronic prolapse, then sometimes it helps because the fibrous tissue will help the bladder later. Okay, so take some snips and find your plane in that, and then push the bladder up to pubic rami on both sides. If your plane is correct, your tissue should not bleed much. Although there are some large vessels supplying the bladder base, and those veins can bleed, arteries can bleed. But if you are careful, you can avoid that. Another thing which I have not written here is always dissect the bladder when it is full, because you will know if the bladder gets open accidentally. It happens. In some institutions, it was considered when you are doing a vaginal surgery, opening of the bladder is a step. So it's a humor actually, because it was so common. The malpractice, sometimes the bad habits are imbibed so easily that, so when you are pushing the bladder upwards in vaginal hysterectomy, you have to take care that you are pushing on the bladder and the peritoneum or on the cervix, not on the bladder itself, so that you will get the pouch properly. And when you are doing cystocele repair, always do the repair with full bladder, because anyway, when you are going to tie the buttressing sutures, you are going to catheterize the bladder. So the bladder will be empty when you are tying the sutures. But before placing the sutures, you have to, and dissecting the bladder, you have to make sure that the bladder is full. Posterior colporaphy. Here, the most common mistake which I have seen is the surgeon, by the time vaginal hysterectomy is over, cystocele repair is over, most of the surgeons get tired, or they don't have that much stamina or patience. So they, most of the time, they justify themselves by saying that the cystocele is not so, the rectocele is not so big, just ignore it. Or they will do some perfunctory repair and leave it at that. There is no muscle dissection, there is no proper vaginal dissection, and such patients will eventually come back with recurrence of rectocele, or they will come back with wall prolapse. So most important thing is your patience here. Okay. Then the steps which are described for rectocele repair have to be followed properly. Dissect the posterior wall till the highest point of rectocele. Dissect laterally till you reach the bellies of lower part of levator ani, because this is important. The parting of levator ani, the gap between levator ani bellies, is the main pathology or main anatomical factor behind rectocele. Because the perineal body is torn during delivery or during because of perineal tear, and the levator ani has gone aside. There is divarication. The bellies have gone side, which are supposed to be centrally. So you have to restore that anatomy. So you have to place the bellies of levator ani between vagina and rectum, so that the anatomy will be restored as far as possible. And so take proper 2-3 stitches on the muscle, then cut the extra vaginal wall if necessary, and then do proper suturing of posterior vagina, and then skin. Okay. Posterior sling, I have already told these points. So this was my presentation. I hope you have gained something from this presentation. I know it has lasted slightly longer than expected. And if you have any questions, we can take those. And I again thank the NIMA-National Society and all my seniors, all my teachers like Dr. Gaisa sir, my guide Dr. Lunde sir, Dr. Daithankar sir, Dr. Pradeep Musale sir. All these people have taught me many valuable things which have come very handy and very supportful for my practice and my development as a surgeon. Thank you very much.
Thank you so much, sir. Dr. Narendra Khairan sir, for this wonderful session. Thank you so much. Sir guiding us with his depth knowledge and his special surgical tips also, which are very important for a new generation surgery. Now, as we all have the gain knowledge as given by Sir, keeping all the steps in mind, we all be prepared for every challenging difficulties that may come during our practice. Sir nicely elaborated the depth of the prolapse, causes, complication, diagnosis, along with the surgical approach. I appeal to all of you for this. You just drop your questions in a chat box. Now, moving forward towards the question session, I would like to invite Dr. Ajay Raj Pal sir to conduct this session.
Thank you, doctor. Thank you, Khairnar sir. It was a very nice presentation. I have one question. As we see many times, hello sir, Khairnar sir.
Yes, yes.
As we see many times, there is stress urinary continence along with the prolapse uterus. So sometimes after hysterectomy also it is seen. So how to tackle it, sir?
You are saying space urinary incontinence after hysterectomy, na?
Yes, sir.
The principles are same actually. If there is a associated cystocele or wart prolapse with it, you have to repair it. Vaginal laxity sometimes increases after hysterectomy. Uterine support is gone. So, right, that post but principles of medical management are same. Vaginal repair with Kelly stitch or peritoneal stitch with associated. There is only incontinence, then Birch procedure will be more beneficial.
Okay, sir. Thank you, sir.
Thank you.
Sir, Dr. Shilpa ma'am asked to elaborate the wall prolapse in the very old patient.
Means obviously wall prolapse after hysterectomy is a difficult situation to tackle. Sometimes what we can do in old patients is surgically, if the patient is not very much fit for surgery, then in such patients, sometimes some people, means I have not performed that surgery, quite honestly, but one of my teachers, Dr. Daitankar sir, I have observed him, I have assisted him doing a sacrospinous sling, which is a very rare kind of sling, which is done vaginally by dissecting the vagina up to sacrospinous ligament. And we apply the sling there and we anchor the wall to that. This is the best operation if performed correctly in inoperable patients or in patients who are aged, who we cannot open their abdomen. But if the patients are fit, then abdominally peritoneal sling or even posterior wall sling can be done. Unilateral sling will suffice. I hope that answers your question.
Yes, sir. Thank you, sir.
So the next question is, during the pregnancy, how safe to treat the prolapse by the pastry? Obviously, you told regarding the prolapse, but still the question is generated. And one more regarding this. Generally, as per your opinion, what is the ideal time to introduce the pastry during the antenatal care, and how you decide the size of the pastry?
Yes, that's what I was coming to. Your question is good. So number one is, we all know that when the uterus sits on pelvic brim, especially in second trimester, after 20 weeks or 24 weeks, the prolapse corrects itself, right?
Yes.
Hello? So the conservative management is done only in first trimester and in early second trimester. So the ring pessary, how you decide? You have to, just as we do pelvic assessment and we measure the distance of diagonal conjugate from inferior border of pubic symphysis to posterior fornix, right?
Right, sir.
So that is the distance which is the diameter of your pessary. 2 number, 3 number, 4 number. According to that, you can decide. Now, previously, there used to be rubber pessaries.
Yes.
Means the rubber catheter, you might have seen that pink rubber catheter. That material. That pessary was quite thick and it was quite painful and it used to cause necrosis in the vagina. Nowadays, we get plastic pessaries. It's a firm but slightly flexible plastic material. Ring pessary is applied by anchoring it posterior in the anterior vaginal fornix, posterior to the bladder neck, and then you lift the posterior end and fit into the posterior fornix and make sure that the cervix is not trapped in there or it is not pressing on cervix, otherwise it will sleep. And sometimes even if you take measurements, the patient may not cooperate or the patient may find it quite painful, then you have to order 1 or 2 size less or more beforehand only. They are not very expensive and it is better to order 2, at least 2, so that when you are changing them, one will be spare. And as I told you that after generally 20-24 weeks, the pessary is not needed. Very rare cases where the cervix is, the uterus has totally lost its support. The cervix will lie outside throughout the pregnancy. In those cases, you might need the pregnancy. You might need the pessary throughout pregnancy.
Thank you so much, sir. Regarding this ring pessary, one more question. Leading to the infertility, how you can deal with that prolapse?
Yes. If the patient is inoperable, according to me, if the patient is inoperable, then only you should use pessary. Or if the patient is pregnant. Okay. If you want to use ring pessary for infertility management or till the patient becomes pregnant, then will she be able to have proper contact? She may be able to have proper contact after the ring pessary is inserted, but she might have dyspareunia or discomfort or some injury if she has contact with pessary inside. And there are chances of infection. Always there are chances of infection because pessary is a foreign body. But you are introducing one more factor, male factor. So it's better to do corrective surgery for infertility. Sorry, for the patients who want child, but they have prolapse. And after the tissue healing is done properly, then they can have contact or further management of infertility by IUI or IVF can be done.
Thank you so much, sir. Sir, this is my personal question regarding this. You are told regarding the deliveries, you just take the episiotomy is the ideal and the time episiotomy is needed for the delivery to avoid this. But how you deal with the water birth delivery, which is the today's eras?
That's what I was telling. Actually, water birth delivery, some people, most of the people, they don't advocate it because it can cause embolism, it can cause infection, and it is not easy to do such things in, I know. And some people do delivery in squatting position. There also, it is very difficult to take even episiotomy, to access the perineum itself. So these things, sometimes we have to do in conventional manner. It is better. Whatever technique you have learned about normal delivery, it has to benefit the patient in long run. If you are delivering the patient vaginally, but if the baby is getting any complication or the patient is getting any complication, there is no point in that novel technique. Our first motto should be do no harm. Right?
Okay, sir. Yes, sir. Thank you so much.
It was a pleasure to interact with all of you, and it was a pleasure to give this small presentation of mine. I hope you people like it. Thank you.
Yes. Thank you very much, sir. Any other questions from the participants? So today we can conclude our webinar. It was a very nice presentation. Thank you very much, Dr. Khairnar, sir,